Welcome to Adolescent and Young Adult Cancer Survivorship, presented by Dr. Lauren Gazelle. My name is Kelly Hendershot. I'm the Vice President of Mission Delivery at Cancer Support Community, and I'll be moderating the session. Before I do further introductions for Dr. Gazelle, I wanted to cover a few housekeeping items. First, as you've been hearing for the past 2 days, this session is being recorded and will be available post-symposium. If you are wanting to earn your CE credits, though, you have to attend live at this time. The recordings are purely for educational purposes. You'll also have to complete an evaluation form. We'll have the link available later today and during our closing remarks, as well as in a follow-up email you'll all receive. If you'd like to ask a question during the presentation, please use the Q&A feature in Zoom. While we will hold questions until the end. If you happen to use the chat tool, I will try to keep an eye on that, but they sometimes get a little lost, so the Q&A is appreciated. So now I'd like to introduce you to our presenter. Lauren Gazelle is an assistant professor in the School of Nursing and associate member in cancer prevention and control at Wilmot Cancer Institute at the University of Rochester. Dr. Gazelle has completed a postdoctoral research fellowship at the School of Nursing at the National Cancer Institute T32 in cancer care delivery. And she earned her PhD at the Rory Myers College of Nursing at New York University. Her program of research builds on her background in economics, clinical experience as a nurse practitioner, and personal experiences to address cancer survivorship in adolescents and young adults. So please welcome Lauren.
Hi, everyone. Thank you, Kelly, and good afternoon or good morning. I want to thank you all for being here. Thank you all for inviting me. Again, my name is Lauren Gazelle. I'm an assistant professor at the University of Rochester in the School of Nursing and an associate member in cancer prevention and control at the Wilmot Cancer Institute. I'm very excited to speak with you all today on adolescent and young adult, or AYA, cancer survivorship. My email is listed here, and it's I'll also be able to share it with you all. Welcome any feedback, any interest in collaborating, and additional questions, and just saying hello as well. So I have no financial relationships or affiliations to disclose. And for this session, just a brief overview. I'll start with reviewing some background and history of AYA cancer. I'll present some hot off the press data just published yesterday on AYA prevalence in the United States, including the epidemiology of cancers present across this population, and then provide some information on the distinct needs and challenges of providing care for AYAs. And then we'll spend some time reviewing resources addressing key social needs of AYAs. So first, I always like to start with my background, my positionality in all of this, because I bring a unique viewpoint to this work, as many of you do. I'm a family nurse practitioner, formerly trained in primary care. I still practice per diem in primary and urgent care settings in New York. And I'm also a researcher with formal PhD and postdoctoral training in AYA cancer survivorship and cancer care delivery research. And lastly, what really drives my passion and commitment to this work is my identity as an AYA cancer survivor myself. I was diagnosed with stage 2 Hodgkin lymphoma at 26, just a few months into starting my doctoral program as a PhD student. Unfortunately, I'm now over 5 years in remission. And so these three distinct yet interrelated viewpoints shape my views as an embodied AYA nurse scientist working to improve the health and quality of life of AYAs diagnosed with cancer. So a brief overview of AYA survivorship. And it's important to share a bit of the AYA survivorship history to reflect on how AYA cancer survivorship came to be and how attention was directed to this specific group of cancer survivors. So back in 2006, the NCI, the National Cancer Institute, the Children's Oncology Group, or COG, and the SEER database worked in collaboration to release a detailed publication regarding cancer incidence and survival in AYA patients. This analysis by Dr. Archie Blyer and his team highlighted reduced improvement in AYA patients with cancer compared with their pediatric and adult counterparts. And this lower percentage improvement in AYA survival in recent decades compared with other age group was termed the AYA gap. Acknowledgement of this gap provided the impetus for much of the recent research and activism focused within this population. Although in retrospect, more recent publications have noticed how time trends in the HIV or AIDS epidemic contributed to the AYA gap as well. So concurrently in 2006, the NCI and the Lance Armstrong Foundation, now the Livestrong Foundation, created an adolescent and young adult progress review group to identify gaps in care and to develop strategies to improve survival disparities. This group described the unique cancer-related medical, biological, and psychosocial issues affecting AYAs. Fast forward to 2012, the National Comprehensive Cancer Network, or NCCN, released guidelines for AYA oncology. And at that time in the US, only about 10% of 15 to 19-year-old patients and about only 1 to 2% of 20 to 39-year-old patients were enrolling in clinical trials. And then in July of 2013, the Institute of Medicine, the IOM, their National Cancer Policy Forum collaborated with Livestrong to convene a workshop in DC. In this workshop, which was titled Addressing the Needs of AYAs with Cancer, had at its purpose the facilitation of discussion around gaps and challenges in caring for AYAs, and then also identifying potential strategies and actions to improve the quality of their care. They published these recommendations in this workshop summary that's been highly cited and a seminal piece of work. And these recommendations are really to improve the outcomes of AYA patients with cancer. Again, this is that landmark report identifying and addressing the needs of AYAs. Then in 2016, NCCN published updated treatment guidelines for AYAs with cancer, and its recommendations emphasized the need for a comprehensive, multidisciplinary approach to AYA care, including supportive care and treatment guidelines that really aim to improve treatment tolerance, compliance, and clinical outcomes. Since the publication of these recommendations in the landmark report, efforts to address the disparity between AYA population and other age groups have been ongoing. And then just last month, NCCN released an updated treatment guideline for AYAs. And the goals of the NCCN guidelines for AYAs, again, are to identify and increase awareness of issues specific to AYA patients and recommended interventions unique to these patients. It also educates physicians regarding the prevalence of cancer in the AYA population and its long-term consequences, also identifying special considerations related to the management of cancer, again, with also hope to promote participation in clinical trials, as well as enrollment in tumor banking and biologic protocols. And a major push has been to raise awareness of who AYAs are and what exactly their unique needs that researchers, clinicians, and patients speak of. An example of this really highlighting advocacy and awareness is the National Adolescent and Young Adult Awareness Week, which was initiated in collaboration with a lot of community organizations, such as Stupid Cancer, and usually it occurs the first week of April. So again, just showing how far the AYA cancer survivorship movement, including research, has come. So who exactly are AYAs? Why should we all care? And for the purposes of this presentation, AYA cancer survivors encompass those from the time of their diagnosis until the end of life. AYAs are typically referred to as those diagnosed between the ages of 15 to 39 years at their initial cancer diagnosis. And in 2020, AYAs accounted for nearly 90,000 patients, 90,000 cancer cases. In 2021, there were an estimated 650,000 AYA cancer survivors living in the US. And AYAs make up roughly 2 to 5% of all invasive cancers diagnosed in the United States, and less than 10% of all cancer survivors. Something of note, especially in the literature, you'll see that the United States may group AYAs within a different age range as compared to the UK or Australia. So the US, we use 15 to 39. Canada may use 15 to 29. Australia may use 15 to 25. And in the UK, they sometimes will say TYAs, or teenagers and young adults, and go as low as 13 to 24. So this is that hot off the press data that I mentioned earlier that was just published yesterday. And for many years, researchers and clinicians have been wanting to be able to cite and refer to the total number of AYAs living in the United States. So these prevalence data show that there are over 2.1 million AYAs as of January 2020. And in the past 4 years, we know this number has grown, so it's a little higher than that. Most AYAs are female, about 66%, and most are long-term. So about 83% are greater than 5 years out from their diagnosis. And because AYA cancer survivors are diagnosed within this age range and living longer than ever before, the highest percentage of AYAs were found to be actually out of the AYA range, right? That makes sense with the greater percentage being kind of long-term or out of 5 years from diagnosis. But they were found to be 40 to 49 years, currently aged 40 to 49 years. And to show a bit on cancer incidence and mortality for this age range, Dr. Miller and her team published epidemiology, I can never say this word, data on AYA incidence and mortality across all cancer types and across all ages. What they found was during the past decade of available data, so in that case it was 2007 to 2016, overall incidence rates increased in all AYAs, but there were differences by sex, showing that incidence may be stabilizing among men in their 20s. They also found rates among men aged 20 to 39 years rapidly increased in the late 1980s and then subsequently declined in the early 1990s. And this was in parallel with the HIV/AIDS epidemic, primarily reflecting a peak in the occurrence of Kaposi sarcoma. And what types of cancer do we mostly see are commonly occurring in AYAs? This figure was based on SEER data, also in Miller's publication, that shows case distribution and percentage of leading cancer types in AYAs, again, from that 2012 to 2016. Because of the wide age range in AYAs, cancers among AYAs vary by age, not surprisingly. For those between the ages of 15 to 19, so that adolescence period, common cancer types are lymphomas, thyroid, leukemias, brain, and then other nervous system tumors. In the ages of 20 to 29, that early or the young adulthood, we also see thyroid, lymphomas, testicular cancers and melanomas, and breast cancer that then starts to rise. And then those between the ages of 30 to 39, that older young adult, breast is more commonly occurring than the lymphomas. But then we also see thyroid, melanoma, colon, and colon and rectal cancer, which we know are also increasing. And then this figure also reporting SEER data breaks up these types of cancer among AYAs a more narrow age range. But again, to show that leukemias and lymphomas are more common during the adolescence period, whereas breast, cervical, and colorectal become more common after 25. Another thing to note is that AYAs are diagnosed at earlier stages than older adults for most cancers, except for colorectal and female breast cancers, which is due not only to screening differences, but also to diagnosis delays resulting from less access to healthcare in this population. So we also review type of cancers that AYAs will present with, and also discussing cancer survival among AYAs. So a little over 9,000 deaths per year are attributed to AYA cancer. This, again, from Dr. Miller's team, reporting SEER data that shows 5-year cause-specific survival by race and ethnicity in AYAs for all cancer types combined. Again, showing that among all AYAs, 5-year survival rate is relatively high, about 85%. However, survival rates are lower among racial and ethnic AYA minorities, especially individuals who are non-Hispanic Black, compared with those who are non-Hispanic white. And when we think of AYAs and the age range, this wide age range, 15 to 39, we consider this time period of encompassing 3 distinct stages of development. we look at Arnett and Erickson a lot to teach us about adolescence and young adulthood and specific milestones that we should be meeting to successfully transition into adulthood. With these stages are significant milestones, again, that are considered vital to development and overall wellness and well-being. And these include identity forming, establishing autonomy, responsibility and independence, finishing education, starting a career, obtaining romantic relationships, starting a family. We know that all of these phases of adolescence, emerging, and young adulthood are complex. They're unique phases of life due to many physical, emotional, cognitive, and social transitions. And we also know that a cancer diagnosis during the AYA life stage exacerbates typical developmental challenges and interferes with the attainment of these important age-specific milestones. Also noting, and there's more research on this too, that with caregivers across this age range, it's different than in pediatric and adult populations in that formal and informal caregivers may shift across the AYA stage, and it may differ among AYAs with varying ages and life courses. So there are also important transitions occurring that occurred among AYA cancer survivors. We know cancer during adolescence and young adulthood occurs at a time of dramatic educational, economic, and social change that poses additional challenges. This experience is compounded by the transitory nature of passage into emerging and young adulthood, and really a time where young people are neither fully an adolescent nor fully an adult, but partly both, and partly exploring what this all means and what they want to be with their lives. So the transition from emerging adulthood to adulthood is profoundly characterized by values for self-sufficiency, such as accepting responsibility for oneself, making independent decisions, becoming financially independent, and cancer has the potential to disrupt this development. There may also be institutional or settings of care transitions. AYAs can be receiving care at either a pediatric oncology center or adult, depending on not only their cancer type, but also their age. And as many of you sitting on here may know, that you may see an 18-year-old with a breast cancer treated at an adult medical center, and then a 22-year-old with a sarcoma or leukemia treated at a pediatric center. So that can also pose some challenges with caring for these patients. And then there are survivorship transitions that reflect back to Dr. Fitzhugh Mullen and his seminal work of Seasons of Survival. So acute being the period from diagnosis to end of active primary treatment, with the focus being on cancer treatment itself. And then extended survivorship encompassing the time from end of treatment to the first few years after, and then the care focus being on, managing the effects of cancer and its treatment. And then permanent survivorship being years after diagnosis until end of life, with the focus on long-term effects of cancer and its treatment and reducing recurrence or the chance for secondary cancers. And what exactly is it that sets AYAs apart? There are many unique aspects of care to consider in this population that may influence outcomes both during and after treatment. Again, we discussed the timing of the diagnosis in one's life course and the developmental status of this age group. Again, it's a time when poor health is really not expected and pretty low on a differential for either primary care or acute care providers. And that the threat of mortality really confronts an AYA at this time when they should not be thinking about death and illness. They also have low engagement in the healthcare system. It may be that they have recently transitioned off of parents' insurance. They don't have insurance themselves, or they're experiencing a new job and they may not have that benefit just yet. So this leads to insufficient awareness of cancer risk and symptoms among not only AYA cancer survivors themselves, but also primary care providers and urgent care providers who may provide considerable care to AYAs in general pre-diagnosis. So this lack of awareness can also result in prolonged and complex diagnostic trajectories, negatively impacting the quality of survival. Next, in contrast to the emphasis put on late effects of treatment in pediatric cancer patients, for AYAs, hardly any late effect clinics, are in place. And the lasting and physical and really emotional impact of treatment at this age is only known to a limited degree. AYAs with cancer are distinct from the pediatric and older adult populations, not only with respect to their spectrum of cancer types, but also to the biology of their cancers. We know that there may be common diagnoses afflicting AYA populations that overlap those seen in younger and older patients. New data have emerged showing differences in disease biology by age. So, for example, in breast and colorectal cancer, there's a mutational burden that in AYA cancers that appears to be higher. Some types of breast cancer, such as triple negative breast cancer, can be overrepresented in that AYA population. So in April 2022, Dr. Tanarezo's team published this as part of a three-part series on cancer survivorship in The Lancet. And the cover is shown here on the left, along with the third paper from this series that really details how more AYAs are surviving longer into childhood than ever before. But at the same time, they also experience a very high risk of late occurring health problems. So this paper focuses on long-term survivorship care for individuals treated for cancer during childhood, adolescence, and young adulthood, and really calls for greater models of care to better support AYA survivors. And AYAs have ongoing needs and challenges distinct to, again, this period in their life course at diagnosis. Common challenges noted among AYAs include the loss of control of their life and disruption of, again, the developmental milestones we talked about. The unknown effects of treatments, a sense of social isolation within the healthcare system and from peers. We know from our qualitative data among the evidence across AYAs, the common stories of AYAs being the youngest one in the waiting rooms, or being there with a parent and hospital staff thinking that it's the parent that's here for their treatment, and so that isolation is very well represented in the literature, and then also isolation from peers, and that they shouldn't be getting cancer at this age, and they should be in school or in their jobs or going to friends' weddings, and how this is a real disruption in one's life. There's a constant balance between hope and risks, and also a lack of evidence-based prognostic information. So, for example, due to this real lack of focus on AYAs for so long, there's a lot of research that still needs to be done to address these unmet needs among AYAs. And then also, AYAs experience a lot of uncertainty about treatments, and that kind of ties to this putting trust back into themselves and their body, and into the healthcare system. And there are significant ongoing psychosocial support needs among AYAs. It disrupts their expectation of optimal physical health at such an early part in their life. But then also exposes them to the premature confrontation of a potentially terminal diagnosis, including anxiety with death and also fear of recurrence. Psychosocial challenges lead to high levels of distress and include things like disconnection from peers and family, increased sense of isolation, and fear of recurrence. In fact, the prevalence of clinically relevant and clinically significant distress among AYA survivors is 3 to 4 times greater than in the general population. And at the same time, greater than 40% of AYAs with cancer in need of mental health counseling do not receive the mental health care that they need. What contributes to this is the significant mental health workforce shortage that specialize in psycho-oncology. I'll say when I was getting my treatment, I waited about 6 months to meet a psycho-oncologist at my treatment center. Because of the specific need to talk to somebody that also specialized in the oncology portion of it. And then also barriers that literature has shown that there are time barriers caused by busy cancer treatment schedules, and then the geographic distance for in-person therapy. And then also one of my colleagues at the University of Michigan, Dr. Anao Zhang, has highlighted here that this can lead to the need to the lack of mental health counseling and the availability. This can lead to the need to create brief AYA cancer-specific technology-assisted mental health interventions for AYAs diagnosed with cancer. And they're about to start a really interesting pilot trial that looks at AI-assisted therapy or technology-assisted mental health interventions for distress and depressive symptoms and anxiety. Around lack of knowledge among healthcare services regarding AYA needs. Much of what we know, much regarding AYA cancer survivorship, continues to be extrapolated from childhood cancer survivor cohorts. And then recent studies have pointed to notable differences between these two patient groups, highlighting the need for really longitudinal survivorship studies specific to AYAs and their developmental status, and particularly their psychosocial needs and the long-term complications of their care and treatment. So I really like this image, and I know it's from 2015, so almost at that 10-year mark now, but it's from the National Academy of Medicine report that I mentioned earlier, and it shows the possible life disruptions for AYAs with cancer. I tend to show this a lot because I like how I use this to highlight how the demands of an AYA's life cycle stages go directly counter to the demands of their illness of cancer. And of course, we know these disruptions can co-occur. So when looking at this, think to your own patients, or think to even your own AYA life, and think about different disruptions that may have impacted you or patients that you see, and in caring for them. There can be disruptions to one's self-esteem, body image, appearance changes caused by either the symptoms or treatment in their illness. And we know these have immediate and lifelong implications to the healthy development and wellness of AYAs, and also disruptions to one's fertility. There's been a tremendous growth of research in the area of oncofertility, really looking at fertility preservation decision aids, improving access to fertility preservation conversations, financial assistance, less of an emphasis on the fertility restoration part of that or the family building part of that. But there has been this growing awareness to give patients the option to pursue a path that they are able, and that they have all of the information needed to make that decision. And I always like to share this personal story here, in that I also went through fertility preservation prior to my chemotherapy treatment. And it was one conversation that really prompted me to do that. And it was a conversation with my oncologist, who said, you don't have to decide now if you want to have kids. You don't need to decide that now. You're starting chemotherapy in a few days. You just need to decide if you want the option. And that changed, my whole mindset, and really taking off a lot of stress of, I had so much to think about and so many decisions to make, and so many things to try to understand in that limited time. And then to figure out, how am I going to come up with $20,000 in 2 weeks to fund fertility preservation? And so through the conversations with my oncology team, and through the Livestrong Fertility Program and Walgreens Heartbeat Program, they were able to make that happen financially. So there are really great services that you can refer your patients to and help your patients with, and that all of these require some provider documentation and forms to be completed. Another example are disruptions to one's peer relations. Many times AYAs note losing friends and family members throughout the cancer experience. It can be hard and difficult to navigate. It can be hard to talk to, disclose to in a school setting or in a work setting. AYAs can feel embarrassed, angry, disappointed, kind of all of that at once. And they're also needing to redefine some normalcy. And so there's a paper that I led during the pandemic, and it was on a study related to work-related goals of young adult cancer survivors. And we didn't know when we started recruitment in February of 2020 that the pandemic would happen a month later. And so we were collecting qualitative data, meaning we were interviewing during the pandemic. And one of these, one paper that came out of it unknowingly to us, we could never plan, but was looking at, the parallels of cancer survivorship as an AYA, and then also navigating the pandemic as an AYA, and then this quote that came out that was like, now everybody understands a little bit more of what we go through when your whole world stops. And so it goes back to kind of what was normal after the pandemic. How do you redefine normalcy? And many AYAs say, it's a chapter in a book, and I can close that and never go back to it. Others like to integrate it into their lives and their professions. I think I'm a case of that in being a researcher in the AYA world. But it really is, it's really driven by the patient and the AYA. And we know, again, there's disruptions to an AYA's education and employment. Many colleges and universities have disability services, disability centers, where patients will register and they can have certain accommodations, or they may need to take a formal leave. And the last example I'll give in this is that, again, I was a PhD student at the time of my diagnosis. I enrolled with the Disability Center, the Moses Center at the time. And for me, it was before the pandemic, so before Zoom days. And they were able to allow me to remote into class for some sessions and offered some extensions. But just that support was what I needed to be able to continue on in the program. So I think it's really beneficial for AYAs who do want to continue working or in school if, they are supported by their care team as well. We know life disruptions among AYAs also help to display the concept of quality of life or health-related quality of life. It's not any one thing. It's this multi-dimensional, multifactorial concept. And another area on here not highlighted, but was also on the previous slide, is spirituality, which we know is really formed during the AYA age range and can also have implications when facing a cancer diagnosis. And we know AYA survivorship is complex. Issues are very different when compared with childhood or older cancer survivors. And one aspect of this that I'll kind of dig deeper in, which is where my area of research is in financial difficulties. I mentioned my dissertation study, which looked at work-related goals and employment in young adult cancer survivors. But I'll briefly kind of pivot into one of the highest unmet needs in AYAs around financial hardship and financial toxicity. So many of us have probably heard about financial toxicity or financial hardship, typically used interchangeably, often defined as the cumulative effects of financial burden and distress among cancer survivors. It has really been shown and really documented to be more devastating among AYAs and more prevalent among AYAs with cancer compared with pediatric and older cancer survivors, because they are disproportionately impacted. They're at this really economically precarious moment in their lives. There's we see that they have very high competing financial demands. So career aspirations, student loans, education costs, also met with limited savings. And that creates a high level of economic or financial vulnerability. I used to tell others that when I moved to start my PhD, I moved to New York City, arguably the most expensive city in the world. I sure as heck didn't budget in a cancer diagnosis. And so I had planned, I thought of myself as a very thoughtful and good financial planner. And so I budgeted that this amount from my stipend would be used to rent, and then I would work per diem as a nurse practitioner, and that would be that would take care of that. And then, of course, I was diagnosed and could not work clinically because I was immune compromised. And so I was really, really stressed financially and how to make this work and how to move forward with my life when everyone was saying, you can move forward, but you feel really disadvantaged, financially disadvantaged. So we know young adult cancer survivors are at a financial disadvantage given their shorter employment history and having had less time to build savings and accumulate assets with monetary value. So benefits at work, things like paid time off, tenure, job security, employer-sponsored insurance, which some employers, your insurance is not, you're eligible until you're within, your employer for a few months or a year. But other things like home ownership, all of those things that are assets, financial assets that can help cover unexpected medical bills. And we know that younger cancer survivors have a higher risk of bankruptcy and medical debt. And we know that financial toxicity among younger cancer survivors, and especially among AYAs, will persist years after a diagnosis, thus placing them at risk of long-term and sometimes persistent financial challenges. So again, my dissertation focused on what we called multi-level factors, affecting quality of life among working young adult hematologic cancer survivors, so those diagnosed with leukemia or lymphoma. It was a mixed method study, so I did both a quantitative survey, and then an interview, a one-on-one semi-structured interview, with 40 young adults who were within 5 years of their diagnosis and were post-active completion of therapy. I asked them questions about their work-related goals prior to cancer, during treatment, and in the current day, and then also had them walk me through the experience of thinking about their future work and career plans. And this led to this concept of what we labeled the survivor's dilemma. And it was published in Journal of Workplace Health and Safety. And it really referred to how AYAs think about work-related goals following their diagnosis and treatment, that they have to balance the following areas that are in this scale here. So the first is their perceived health and workability, asking themselves, can I do this work? The second is around their self-identity, asking themselves, do I actually want to do this work now? Does this give me the meaning that I want in work? And then the final being financial toxicity, and can I afford to or not afford to do this work? And this wasn't a longitudinal study, it was just at one point in time, but we don't really have the weight of these factors, meaning we don't know what drives this decision making the most. It can be an equal combination of all of this. For some AYAs, it can be more the financial factors that lead them to kind of forego. Doesn't matter if this job is meaningful, it's just a job. I'm going to it 9 to 5, and I can still physically do it. And, it gives me good health insurance and good benefits. Whereas others are like, this completely transformed how I think about work and how I think about engagement in as an employee. And so even though it's a really great paying job, I'm going to go back to school and be a social worker or be a nurse. And so it was a lot of rich, we call it rich qualitative data, but a lot of great quotes. And so I'm happy to share the publication later. And this is one quote from this study from a young adult cancer survivor of lymphoma who worked in the healthcare sector. And I found that it really encapsulated the survivor's dilemma theme when they said, it's a mental thing. Your mind thinks that you need to go and do all these things. I survived cancer. I need to go out and live. But then you get done with treatment and you're like, but I have to save money because what if something happens? Yes, you can go and do things. However, it almost comes with a catch. The one other recent work that I'll share falls under this financial toxicity domain and really around um, financial resources and addressing kind of social needs of financial hardship, but it was around crowdfunding, medical crowdfunding. And specifically, it explored the perceptions of crowdfunding among young adult cancer survivors. And we know that the need for financial support, especially among young adults, has led to the emergence of medical crowdfunding and also the growth of social media in this population too. So crowdfunding, using social media platforms to campaign for donations of funds from the crowd or from the multitudes to offset an individual's medical expenses. It's become common in the United States. In 2019 alone, 1 in 5 Americans reported that they or someone in their households contributed to a medical crowdfunding campaign. And then one of the most common or the most popular site for crowdfunding, GoFundMe, reported that 1 in 3 of its campaigns were created to help offset costs related to treatment for an acute or chronic medical problem. And I think just today, I just didn't have time to put it in a slide, but in JAMA Cancer, there was a publication from Dr. Yabruf, who's the scientific officer at the American Cancer Society. Her team published looking at GoFundMe data and online crowdfunding forms and with the use of ChatGPT, if it was able to describe these crowdfunding campaigns. So don't have access to that yet, but I will be reading that shortly. We know that past research has looked at this large scale analysis, so it's been able to pull kind of all these campaigns into think of it as like a big spreadsheet, Excel spreadsheet. But we actually we qualitatively questioned young adult cancer survivors to ask about their experiences with crowdfunding. And we published this in the Journal of Cancer Survivorship. And we surveyed young adults who had received a financial assistance grant through, at that time, it was called the Sam Fund Foundation, now is the Expect Miracles Foundation. And we found these overarching themes within the crowdfunding compromise. So the sub-themes that crowdfunding was useful and helpful. There were factors associated with crowdfunding success. And then there was this theme around questioning the why. Why was it that they had to be vulnerable with their diagnosis and have to essentially put it out there for the whole world to see to be able to get financial support? So the majority of crowdfunders acknowledged that this crowdfunding was helpful to address their cancer-related financial burden. Some called it a lifesaver, that they wouldn't have been able to get treated without it, that it helped cover their immediate expenses. And then they also had mentioned some factors that they perceived had helped. So we call them facilitators and barriers, so things that helped or hurt their ability to crowdfund. And interestingly, the majority, about 60% of these young adults perceive that their age alone and socioeconomic status of their community facilitated their crowdfunding efforts. And it kind of leads to the discussion of like success begets success. If you're already in a affluent community, the likelihood that you're going to have a more successful crowdfunding campaign is high. And so I'm also happy to share that publication if others are interested. I wanted to share some barriers and opportunities for AYA cancer research and cancer care delivery in general. And some of this is reported from a systematic review and a review of papers that looked at barriers to clinical trial enrollment and barriers to caring for AYAs with cancer. We know that progress has been made by creating, many institutions have created AYA programs, and also increased the development and availability of clinical trials for AYA patients. But we also know that although the number of programs for AYAs with cancer is increasing in the US, there's no formal accreditation or registry that exists to measure these programs. And so the structures available and the services offered vary among programs. So there are some opportunities, again, within these formalized AYA oncology programs. Another opportunity is to improve access to protocols through the development of a clinical trial network and community-based trials. There's increased synergy among these clinical trials, cooperative groups like ECOG-ACRIN and COG and Alliance, that many studies have been able to participate in kind of pilot trials of recruitment through, let's say, whether they're an NCORE site or a non-NCORE site. And then we know that also patient-level facilitators to clinical trial enrollment and engagement really focuses on them, including them in the decision, building strong, trusting relationships between AYAs and their providers. AYAs also endorse that they want to give back to research into the AYA community, and really that desire to further science, whether it's on their specific type of cancer or for survivorship and quality of life outcomes. And we know that AYAs are often characterized as being digital natives, so they can be more savvy compared with other patient care populations. So there have been, a lot of literature done on social media and recruitment and retention of AYAs, and whether that is optimal in reaching AYAs across the US. We know, though, AYAs still have low clinical trial rates. We can decrease some of the barriers to clinical trial, especially around insurance. Patients are often unaware if their insurance cover clinical trial participation, and the most common insurance coverage among AYAs is employer-sponsored insurance. So there have been tremendous efforts to increase AYA's knowledge of their health insurance and their health insurance literacy and cost literacy through some novel intervention studies out of the University of Utah and Memorial Sloan Kettering. And then also at the provider level, we know that having the conversation with patients directly is the best. Patients want to hear it from their providers, and they don't just want to see flyers in the waiting room or some email in passing. That firsthand from providers really increases that ability for them to ask, reach out more, ask more questions, and enroll and engage in the study. When we think of treatment-specific effects, I think we often think about how it can interfere with the everyday life of an AYA, and the ability to participate in their roles and in their functions. So whether work or school, so things like chronic fatigue, nausea and vomiting, insomnia, nerve problems as a result of treatment. And often specific late and chronic effects do vary based on each AYA's disease and treatment. We know that sexual dysfunction is a well-known but still under-researched consequence of many cancer treatments across diagnoses. And we know that secondary malignancies are a particular concern for AYA survivors who've received specific types of therapy. So NCCN guidelines do recommend specific radiologic testing and additional cancer screening based on type and dose of treatment. So referring to NCCN guidelines that are very recent. We know also AYAs are at higher risk for most chronic medical conditions like diabetes, as well. AYA survivors experience significantly higher incidence of anxiety and depression and post-traumatic stress disorder. We talked a bit about mental health providers and that provision of care, and also the concerns about relationships and costs of care, financial hardship. Fear of cancer recurrence, we know, can be paralyzing for AYA survivors, and many AYA report wanting more support and just more education on managing these fears and concerns, especially around fear of recurrence, anxiety, and really in returning to work and school as well. And so referral to specific services related on what is driving the fears for these AYAs. And we know there's been much work done on development and implementation of standardized financial toxicity screeners, financial navigation programs to identify patients at highest risk. And then also really referring to services both in and out of the community setting that can help address some of the highest unmet social needs. I think one final note here, really just honing in referral to the appropriate support. AYAs survivors often say they feel left behind, especially after that treatment ends. I think the most resounding quote we always hear is cancer doesn't stop when treatment stops. And so referral to social work, to financial navigators, to community-based programs that can really help facilitate either return to work engagement, family building, all of those things that AYAs really feel are integral to continuing their life. And so then they always leave with some resource list. Of course, this is just a small sampling of that. There are many, many other resources. Patient Advocate Foundation also has the National Financial Resource Directory. Cancer Care also provides research, navigation, young adult support groups. There are specific affinity organizations. For example, ESCAPE is one of the first and only AYA organizations for LGBTQ AYAs that provide support groups, and then Immermini Angels through peer support, and so there's physical activity, there's outdoor activities through First Descents. The list goes on, but I know I'm a little over time, and so I saw Kelly just came on, so I'm going to wrap up there. I'm sure there's a lot of questions, or maybe not, but I'm happy to answer any questions. And again, feel free to reach out, and just thank you so much for having me again.
Thanks, Lauren. And we're doing okay on time. We have about 7 minutes left. I just want to be prepared to help with the Q&A.
Yeah.
The first question we have is, this is from early in your presentation. What do you think drove the increase from 2020 to 2021?
I was probably back to, I'm assuming this was based on the incidence data.
I believe it was the incidence data. The person asking the question is just noted as guest, so if you have more details to provide, feel free to do so, but I believe it was.
My gut, I don't know if we had, well, we know that there's specific cancers that are driving this increased incidence in AYAs, specifically around colorectal and breast, and also thyroid cancers. I think this report that came out, publication that came out yesterday, really called out more research needed on thyroid cancer and AYA survivors of thyroid cancer. And so we know that causes of some of those cancers have been linked to genetic factors, but then also obesity as well. I hope that answers some. I'm happy to look into it more, and I'm not an epidemiologist, and so I can report on what I see in some of the data, but it's a great question.
Right.
And I'm chat too,
The other
yeah.
question was about one of your resources that you talked about. How do we get a copy of the Survivor's Dilemma?
Oh, I'm happy to. What I'll do, Kelly, is send you that publication that I believe is open access now, but I happy to share in a PDF.
Oh, great.
Yeah,
And then we can share it
yeah,
with all attendees.
yep.
Perfect.
Mhm.
This next one's not so much a question as a comment. And Kirsten, I don't know if you want me to unmute you so you can just share this yourself. Trying to find my participants list to see if you're responding to that. Oh, yeah, she said that would be fine. So now I just need to find her. Bear with me. Oh, thanks, Julia.
Thank you. Yeah, so Gilda's Club Madison has been partnering with Gilda's Club Middle Tennessee to offer a program connecting with Chelsea Gomez, who is an AYA artist that we do Tough Friends Art Club. It's a activity that happens about once a month, sometimes twice. And we've been pulling participants in from across the country, but it's a really great way for AYAs to connect virtually, but also right with each other in a very it's not a therapeutic, but it's a therapeutic thing. So thank you very much for yeah, hi Megan.
That's great. And
it's
yeah,
wonderful for participants. Yeah.
Yes, and Chelsea, I followed Chelsea on Instagram because her graphics are just beautiful and adorable and like find me chuckling. That's a great resource. Yeah. And I love that. I think we've gotten really creative in the AYA space to meet AYAs where they are, and that some want to go rock climbing in where is that country that I'm blanking on, our state in Colorado or somewhere in the West. And then others want to do a peer support navigation through Immerman or do a like an art therapy. I think I think we should be having multiple options available to address AY to really address AYs where they are. And I know for me, I would have loved that. And I think the whole AYA support, the question that I get a lot sometimes are about AYA support groups within cancer centers, because there has not been the highest levels of engagement within within the cancer center, and that can be for many reasons. And for me, it was many of the AYAs weren't living in the same state that they were receiving treatment, and so coming back in for and again, this was before we could do things on Zoom like this. So coming back in for an hour meeting was really challenging. And so why not do things more in the community and so I think again, Zoom and the virtual option has helped that, but also some people do want to be physically in the same space and sharing that same space. So thank you. I'll tell Chelsea you shouted her out too.
Yeah, I see another comment in the chat that please remember lots of CSC and Gilda's Club have specific AYA groups for local communities. So thank you, Megan, for making that plug so I didn't have to. I think I did get another question in. And that is through Gilda's Club, and who else is it the virtually offered any AYA, even if you do not live in Middle Tennessee, or is that only for the person in that area? So that specific program that they were talking about is a collaboration between Gilda's Club Madison and Gilda's Club Middle Tennessee. It is not a support group, it is an art group, so that does enable anybody in the country to participate. All right. Well, I can say as a former AYA caregiver, I wish we had the resources 16 years ago that we do today. We've really come a long way. There's a lot of improvement to be made, but it's great to see people like you, Lauren, doing this kind of work to further that.
Thank you so much. And yes, please reach out. I'd love to hear from you. And thank you again for inviting me to be on.
Thank you. And so that is our final session. We will have closing remarks immediately following this, but just as a quick reminder, this was recorded, so recordings will be available, we hope, next week. If you are getting CEs, there will be a link shared during the closing remarks session. as well as I believe maybe just now in the chat. So you will record all the sessions you attended, and recordings will be available until February 10th, 2025. You did have to attend live though to get CEs. So thanks again for joining us. We look forward to seeing you in just a moment here in our closing remarks session.